So welcome to the TechPulse Healthcare Podcast. Into season two, I've got my co-host Jonathan Probert with me as always. Hi, Jonathan.
Hi.
Hello. And we're honored to have Kristen Valdes with us. Kristen, I'll go through what my understanding of your background is, and then you can. I always like people to correct me if I've gone astray. But you're the founder and CEO of b.well Connected Health, a digital health platform, as we just established in Baltimore, Maryland, headquartered there. And you're a healthcare executive with over 20 years of experience, widely regarded as a visionary in the consumer-directed digital healthcare space. I saw a number of awards that you have, and it's too many to probably read out, but EY Entrepreneur of the Year 2025, Top 50 in Digital Health, 40 Under 40 Healthcare Innovator, Top Innovator, an Accenture Award, and there's loads, right? So yeah, it's really amazing what you've achieved. Where we wanted to kind of start this story is really with your journey and the journey of b.well, and understand your daughter Bailey and her birth and your experience with her had a big influence on it. So I was wondering if you could talk us through just how that happened.
Yeah, I'd be happy to. I had the good fortune of being a healthcare executive before my children were born. As I was building companies, I was also building my family, and I have three children. My middle child, Bailey, was born with a fairly significant autoimmune condition. And, here I was, this quote unquote industry expert, and I found it nearly impossible to navigate the healthcare delivery system for her. And I was the mom who knew just too much about healthcare, trying to find something wrong with this otherwise perfectly healthy child. And then when she was 7, she was given a routine medication for a sinus infection from her pediatrician that nearly cost her life. And it was because two EHR systems couldn't talk to each other. And so she had a drug to disease contraindication. It was the first time Johns Hopkins saved her life. I'm very loyal to this system. They have phenomenal medicine worldwide there. And they not only saved her life, but at that point started to really take me seriously, that there was something underlying that was really wrong with this otherwise seemingly perfectly healthy child. And as she progressed through her life and she went into adulthood and into college, we had another major incident where we actually lived inside of Johns Hopkins Hospital for about 9 months. And that was just under 3 years ago now. And so she was officially diagnosed rare disease, N of 1. She is on a off-label use of a medication that saved her. And she is now 23 years old and costs $550,000 a year to keep alive just on her maintenance meds. And we import one of her medications from another country to save $250,000 a year. So we get to live the healthcare delivery system all day, every day. And the reality is that it just doesn't work for patients and caregivers the way that it needs to.
Wow, that's that's a pretty personal story for yourself. We talked to a number of entrepreneurs and people who have startups, and they come in different ways, but I think this is quite unique and close to heart. And so what does so if I was to ask you a kind of dummy's guide of what b.well actually does, could you explain just briefly what it is?
Yeah, I tell people we do the really unsexy part of healthcare, the stuff that nobody really wants to focus on. We modernize the back end. And what that means is that on our platform, we do 3 key things. One is we help create a full longitudinal health record for consumers. So we have the largest footprint of connected health data in the US market. And we create a semantic interoperability layer that sits on top of that, which just means that thousands of backend systems that are proprietary, we can turn into something that makes sense at scale. And then we surface insights on top of that data, because if you've ever seen healthcare data, it was not written for patients or caregivers, it was written for doctors. And so we surface insights in plain language English, helping people understand when they have gaps in care, aligned to best practice evidence-based medicine. And we allow them to share their information back to EHRs or providers or other apps that they see. And then we connect them into access. And access, I think, is the real war to be won. And think of it as simple as if we're letting somebody know, if somebody's chatting in an LLM platform and says, look, my husband just stepped on a nail. When was the last time he had a tetanus vaccine? And they're just talking to their medical record. we not only can give them the date of the last tetanus vaccine, but we can give them options to say, a Walgreens pharmacy has an appointment availability within 5 miles of your home, here, 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 and here. Would you like us to book your appointment? So we think of it as a flywheel. More data creates more insights create more access generates more data, and then we take our flywheel out from healthcare and into health, into wearables and sensors, how you're sleeping, walking, moving, stress levels, heart rates, and things of that nature.
Wow.
It's amazing. I mean, to hear somebody who's actually cracked this nut is quite inspirational. So, a lot of my problems over here in the UK, Kristen, are relating to the very things that you seem to have solved: silo data, platforms that don't talk to each other. Do we use Fire? Do we use OpenAI? All these kind of debates that are consistently going on. How did you? I mean, it's an impossible question to answer probably, but how did you get all these things to talk together? Who did you actually need to engage in order for people to say, okay, we're going to go with you?
Yeah. So I liken my journey to roller skating uphill carrying a boulder. So the first thing that needed to happen with this vision was that in the US market, we had to change the federal law. And so for the last decade, I also have served as a board of directors member to an organization called the Karen Alliance, which is a private-public partnership that brought together big tech companies like Apple, Microsoft, Google, Samsung, and it brought together the federal government, big payers, big health systems, and third-party applications and patients. And we ultimately said, what do we need to do in order to make this vision a reality? And the reality is that we needed to change the law. So many years ago, sister laws came out, one called the information blocking rule and the other called interoperability, and they were sister rules that in short just meant every patient or person in the US now had the basic fundamental right to access their full longitudinal health record through any trusted third-party app of their choosing. And for the first time in history in the US, it dictated the technology standard to be utilized, which was an open API. So that's when really FHIR started to advance in the US market. And of course, it's advanced across the world in many regions, sometimes even faster than in the US. I got to write the FHIR guidelines for payers for the US and bring them through balloting processes and then do early demonstrations. And then we did the what I like to call door knocking. So we went to every payer and provider who was obligated to create these open APIs, and we worked on getting them connected. And over the last 7 years, we've managed to amass more than 2.4 million providers, 340 payers, labs, pharmacies, Medicare, the Veterans Administration, and over 600 different wearable sensors and devices. So pulling all of that together took a lot of time, which was when we started receiving the data and figured out it was rubbish, right? And that we really needed to create semantic interoperability and codable concepts, that FHIR was really designed for, but bringing in outside information where we could really cleanse the data, like SNOMED and LOIC codes and all of the, kind of code sets that EHRs and payer systems operate under in order to make that data make sense. And then with the, rollout of LLMs across the world, we saw this massive acceleration. And so we started to deploy that data onto an MCP server focused on really fast response times so that any consumer can now chat with their medical record in less than 1 second response time.
So just to reverse back to the Bailey, kind of what happened with her and what you were telling us. So the issue, just to finish that, round that off, was that there were systems not talking to each other, basically. And so that there was data that one healthcare provider had access to that another one didn't. And that was causing, it wasn't replicating across or anything like that. It was just looking at two different things, and that caused the problem. Well,
yeah, she had seen several specialists, and specialists had ran some diagnostic testing that resulted in a diagnosis code that I was unaware of, and they did not offer a patient portal at the time. And her pediatric system did not have interoperability with the specialist system. The two EHR systems, even though they were the same platform, did not talk to each other. So it was a knowable event. And I mean, in the US market, medical error is the third leading cause of death in this country. And a lot of it has to do with data exchange and lack of interoperability. What was most telling to me was once I found Bailey's diagnosis, and unfortunately it was me, but that happens with a lot of us mama bears, right? Was that I tried to once, she had her first near fatal incident, I took to the internet, as all good moms do. And I tried to pull all of her medical records, document all of her symptoms. And Dr. Google helped me identify, after 2 days of research, and I mean morning to night, I finally read this definition of lupus, which was the first thing that I realized that she must have been suffering from. And I just remember tears coming to my eyes because I had finally found the monster that I was fighting. And it explained why all of the doctors really dismissed us, because these things would come and they would go, and they were inflammatory responses and short acting. And it was very easy for people to explain away daily symptoms because they were never super severe until that moment, as family history. Like, oh, you have a rash on your face, you must have a family history of eczema, and therefore, not something to pay attention to. And then as she progressed into rare disease, one of the things that we noticed was that none of her physicians, her dermatology, her rheumatology, her nephrology, all of her general care and primary care, none of them had the ability to communicate with each other. And so they weren't operating with her as a team approach until, we spent 9 months living in a hospital where we forced all of the varying specialties to come together and communicate to determine exactly what was happening. And then we did advanced genetic and genomic screening, which in the US only Hopkins and the NIH could have done. And they mapped her exact biochemical pathways to the drug that actually saved her life and stopped her body from attacking itself. So we know a lot about the healthcare delivery system, but the reality is even with the modernized technologies that we have today, our core systems don't talk to each other, even sometimes within the same facilities. And that is problematic.
So it did, and so that I know then you've kind of left your secure job to jump out and do this, like many entrepreneurs do, I know, but you're really motivated.
All founders have a little bit of crazy in them, and that was mine.
Well, there's a leap, isn't there? Yeah, and so you and your motivation was obviously to help your own daughter, but also maybe to help others out there who are, I guess, as a kind of middle, where you're kind of between the patient and it sounds like the healthcare institution. Maybe you don't really get to see or hear, or do you, from any end users or patients that benefited, or
we definitely do. We get all kinds of stories from people, especially with LLMs, when OpenAI launched, and similar stories when Anthropic launched and many others. There was I just remember on one of the LinkedIn posts where someone was saying, never give your data, to any LLM or AI. And a patient came on and said, I've been using ChatGPT long before the health item really came out or was launched. I've put all my medical records in and self-diagnosed a brain tumor that 2 of my physicians completely missed. I then had it validated with those physicians, had brain surgery, and I'm now on, my health journey because my symptoms were being ignored. It was all right there. It was even in the imaging that I already had taken. So, the reality is that, we are definitely hearing, especially from caregivers who are caring for their kids and for their parents, the ability to not have to navigate, 10, 20, 30, 40 different portals to try to figure out what's going on with mom, with dad, or with the kids. Being able to just have a convenient place in their pocket where they can manage their whole family in one place has been really life-altering, even from a time-based perspective, an administrative burden.
Yeah.
Has there been, have you encountered much resistance from the monolithic EHRs in terms of having access to the data?
I think we have to acknowledge that when you unleash the data from monolithic EHRs, that it threatens their business model and their moat. And any organization is going to pull back in the opposite direction. I think there are some really good EHRs that are saying this is the right thing to do. We just need to make sure that the way we do it is private and secure. I take issue with those that say we have to control it, because the law very much says that patients can choose an app and they can pull their data down, and the provider or the EHR has no say in that. They actually have to comply. But there are a lot of EHRs who oppose that, who want the authorization to come through the EHR. They want the portal account. I like to call it Portalitis, right? The diagnosis I think we can eradicate in our lifetimes, the login and password, because they get paid every year for people to have access to that portal. So as we've thought in the US market and over the last 6 years, we've brought modernized identity into healthcare. I always say if you can use your face to board an airplane, you should be able to use your face to pull in your medical record. We know that it's you. And so if people have that IAL2 or that level of security, the liveness detection, we know that it's you. Why do you need a login portal and password? I mean, it's so much more secure to do modern identity. I mean, today I log into my daughter's 30 plus portals all the time, and her doctors don't know that it's me or it's her. She's an adult now because we share credentials because I manage her healthcare. So, moving into more modernized identity is great, but there's definitely resistance to keeping that portal account in place because it threatens a business model where people make money.
Absolutely. So as a frontline clinician myself, Kristen, I would love the people that I care for to have access to this kind of stuff because it's it's giving them autonomy and agency in a far better way than I can ever explain. What do you think it's going to take for this to take off in Europe and the UK?
I think we need to look at best practices that are working across the world, right? The US took a big nod from what Australia did, when they created more of a central record system. Now, we're not going to create a central record system in the US. It's just never going to happen here. And I think most people are opposed to that. But having the ability to move from a system-centric environment to one that is consumer-centric and giving patients right to choose any app and requiring providers and payers to must comply through open API infrastructure was what the unlock was that created competition, right? And we created competition in a way that apps could come out and add value. Like some might price shop your family's drugs, and just tell you when you can save money. Others might match you to clinical trials for people with rare disease like my daughter. But we give agency to consumers to be able to make those choices. And so I think in order for that to take off across the world is that we need governments to follow like suit when things are working and put those same rules and regulations in place that give people the basic right. I mean, it was one of my favorite stories about Bailey was when we were getting ready to discharge from the hospital this last time. A doctor came in and sat on the bedside and said, Bailey, for people like you, it's really, really important that you have your medical records with you at all times. And she's like, and she brought an example of a binder with pages and pages and pages of medical records. And she said, I know it might seem inconvenient, but no matter where you live in the world, you need to have this with you at all times. And the doctor left and my daughter looked at me and she goes, Mom, I don't think she knows what you do. And she said, I wanted to just pull out my phone and say, I have my records right here. She goes, but she was on such a roll. I felt bad telling her that.
That's a great story. Yeah. I guess the other consideration here is, whilst consumer demand is rightly driving this, and there's an ethical justification for the whole thing, which
Yeah.
I fully support. The risk is, I guess, from what I'm seeing, is that AI application of patient data is being weaponized almost. It's creating this divide between the clinician and the general public where it needs to be a kind of a shared decision surface,
Right.
which is hopefully what we're moving towards. What advice would you give maybe to people on my side of the fence, the clinicians? How do we engage in this in a more positive, less defensive way?
I think one, we just need to acknowledge as a society that change is hard for people. And that's all kinds of change. And so fundamentally, we're going to try to find the flaws in things. And when we think about AI, it's not a question of do we or don't we? It's already here.
Hmm.
The need has clearly surfaced because there is a gap in the market for patients to get information they need at the moment that they need it. For us to say that it needs to be perfect or it's dangerous, I think is a little bit disingenuous because we need to compare it to what is the alternative today. For people in rural communities, the alternative is zero. It's complete absence. For people who do have access to care, it's, well, maybe I can't even get into my doctor for 6 to 12 to 6 months, like weeks to months. And so when we know that people are already using it, I think doctors do have to go through some change management to recognize that you are going to have a smarter, more intelligent patient coming in who is informed, and that you are going to move from you do what I say because I know best to a shared decision-making model. And I think the doctors who do that well are going to succeed. I think those that keep pulling back in the opposite direction are going to lose a lot of patients because they won't feel heard. And today there may not be an alternative, but I do think that it's also and I'll just be a bit controversial, but right now in the US, more than 80% of providers are already adopting tools like Open Evidence and others where they're using AI in their own practice. And I think pretty soon it will be negligent to not use AI when diagnosing and treating, versus whose liability is it if the AI is wrong, right? So I don't think AI is trying to replace physicians, but I can tell you that AI has a much better memory than any human I've ever encountered or come across, with more current access to information. And I think we are heading in that direction very quickly. And so I do think we need to start focusing on change management within our physician practices, because I think the role of a doctor changes whether we like it or not.
Yes, I actually, so I work in IT, so I'm not directly in healthcare like Jonathan, so I'm more of a patient probably on that side of things. But I do work in transformation and change, so I hear what you're saying a lot, and I understand. I mean, data is one of those things that's precious, and there are fears, probably some of them, yeah, just going to disappear anyway over time because the wave is coming, right? But I think everybody does have responsibility, and I've seen you have a lot of protocols and things like that to secure people's data and give them that confidence. As far as it coming in the UK goes, again, as a patient, perhaps a bit naively, and maybe fortunately I haven't had to deal that much with it. But I actually thought, oh, it's a US problem, because you're all private. We have the NHS here, right? That it's our precious NHS, which is the umbrella and covers everything. And I thought this must be a US problem again. But then actually just last week I went with my mother for an appointment she had for a procedure. And in one department we walked in and they asked us to fill in a form, and it had her name and they asked for her who her doctor is and things like that. Filled that in. And then after the procedure we sat with a nurse, just to get the results and what happened. And in there that her name was spelt wrong. And her doctor, she was saying, "This is your doctor." I said, "No, that was when my father was alive 25 years ago. He was her doctor." And so they had that name down. Well, like, how did you at reception you had one completely different set of data, and now we're sitting with a nurse in the same department, not even in a different part of the hospital. So, and then I was thinking about this that we're doing today, what we were going to do, and I thought, actually there is a bit of a case, isn't there? Perhaps not as fragmented, I'd say, maybe as the US, maybe because just the size of it, and you have more people. And maybe our NHS does do a little bit of consolidation, but there definitely is. No, I'm hoping. I'm really hopeful.
It's crazily fragmented.
No,
You would not believe it. Even within a single hospital, there'll be almost 100 different IT systems. Many of which don't
that
talk
was
to each
one
other.
department within a hospital out of many, and
Right.
even in there they had it two different bits of data. She said, "Oh, I'll have to update the other system." So what's going on?
Yeah.
And when you work in IT as well, it blows your mind a bit more as well as to what's going on. But
We have a new initiative that's actually launching next month in the US, and it is lovingly called Kill the Clipboard. So patients now have the ability to pull their longitudinal FHIR record, and through a basic QR code can push it to an EHR at the point of care, so that they can stop filling out the forms at the doctor's office, and the information that should be known about a patient can travel with them to any physician that they see. And it is patient generated, meaning that the provider doesn't have to agree to receive their record and their information, that the patient has the basic right to push that information, so that if a physician is in fact using AI on their behalf, that the patient can say, "But I want you to have all of this information about me."
yeah, and those fears that people have, I think, are always there. When things were computerized in the first place, although they've all become fragmented, there'll be a fear then as well, I'm sure. I remember when I was little and I was in my dad's surgery, and we used to open these huge drawers, and it had these cream files for each person, and it shouldn't have been. I was probably rummaging through them. I don't know what people thought, what sort of security people think happened in those days, but clearly not that much. But they didn't, you don't really, like you said, what's the alternative? What are we doing now? You don't realize what you're comparing it to. So just before we wrap up, quick question around the OpenAI deal that you had that's recently announced, and people would have heard. Maybe if they heard the company name will associate it with that. Just how did that come about, and what does that look like now?
It really came about from the CMS Health Tech Ecosystem announcement, it came out last fall. It's a voluntary pledge. HHS and CMS came out and said, "Hey, look, we want companies who are willing to help us solve for interoperability once and for all." And they wrote a basic criteria of using open API infrastructure on FHIR, following a data standard called US Core, and not requiring portals for the first time to give patients access to their data, to kill the clipboard, and to something called conversational AI. So while the US government expected maybe 10 companies to come to the table to say, hey, yeah, we'll do this, we have this infrastructure and we will work with you on it, they had to cut it off at the first 60 companies right before the announcement because everybody was trying to come in and be involved in the launch location couldn't hold that many people. And then, since fall, there are now more than 600 companies in the US who have pledged to meet this criteria. And that is how we met a lot of like OpenAI and a number of other organizations that we surfaced, but they made a pledge to provide conversational AI to people in their health. But nobody really wanted to spend $100 million in 7 years trying to create the pipes that you could connect data for. And given our national footprint of data connectivity for patients, because we did the uphill climb and the door knocking, it became a really obvious partnership for us with a number of US organizations so that we could provide the pipes and they could focus on the thing that they're really good at, which is the value on top or the conversational component. So b.well has been very fortunate that we, I would say, we saw where the puck was heading and we went there before most folks did. And so now we're quite busy trying to service as many companies as we can to meet their pledge obligations where they don't want to start from scratch and build this on their own.
Well, that's really amazing. And so from a ChatGPT type perspective, how does that work? The connection to your company, and what's that like from an end user perspective?
Sure. So when you go into ChatGPT and you put in a health related query, it prompts to see if you want to create an account in your for ChatGPT Health. It is a completely separate component of ChatGPT, and that is because they wanted health related chats to be separated from all the other chats in your normal account creation. There are prompts at the bottom of ChatGPT Health that just say, do you want to connect your medical records? Or if you're in conversation, it might prompt you. And when you click yes, you want to, you can type in your doctor's name, your health system, or we can find things that are nearby and make recommendations for you. You can connect directly into your payer provider systems and your data comes in and you have the right to delete your account, the right to be forgotten. The data is not used to train on any AI model. It is completely separate. So it is really consumer mediated and controlled, which is very cool.
Wow.
Amazing.
Yeah, amazing. One last question for you. Just what does the next kind of 5 to 10 years look like? What can we see happening?
Well, one, obviously global expansion. We've proven out the model, and if you can make something work in the US healthcare system, I think you can actually replicate it in other places because we make things so darn complicated here. But I think the real war to be won is on access. Looking at your data and getting insights on your data is one thing, but we've got to make it easier for people to find the care they need at the moment that they need it. And so we're working very hard in the US to have all health systems and providers and pharmacies and people. If you think about healthcare, it's a service business. And we don't treat it like a service business. I mean, I can open up my phone and order an Uber directly to my house or book a reservation, instantly. But I can't do that for doctor's appointments. I can't be matched to the right doctor who has seen the most patients like me. I don't know whether certain things can be treated virtually versus in person, and I certainly don't know what's covered by my health plan. So for us, it's getting to true shoppability, where when you're in that chat and you have a need, that the options for you to receive care pop up directly within that experience and are already smart enough to know what's covered by your insurance, what you would have to pay for cash, or if you can be virtual or in person or even digital. So we can help for the first time service healthcare beneficiaries with what they need at the moment that they need it versus putting the burden on them to go figure it out.
Great.
Wow.
Well, Kristen, thanks for your time. That brings us to the end. It's been a pleasure. Thank you to you both.
Thanks for having me.
No problem.
Yeah,
no
thanks
problem
for
at all.
having me.
Thank you, Kristen.